Hello, bonjour. J'aimerais dire d'emblée que je suis Peter Julian, député de New Westminster-Burnaby, et on vous parle dans cette conférence de presse importante sur le territoire traditionnel non cédé du peuple Anishinaabe-Algonquin. This is a very important press conference, and what we have here is experts from various parts of the country that are here to talk about concerns that have been raised around the Canadian Task Force on Preventive Health Care. Alors, quand on parle de groupe d'études canadiennes sur les soins de santé préventive, c'est nommé par le fédéral qui met en place la grille de pratique sur les maladies. Comment on peut, bien sûr, faire des tests de dépistage, quand ça va être consacré, quel type de test et bien sûr à quel âge ces tests-là pourraient être prévus. Mais on voit de plus en plus un écart entre les pratiques qui sont recommandées par le groupe d'études et qu'est-ce qui arrive, bien sûr, dans les provinces canadiennes et qu'est-ce qui arrive sur le sol international. Comme vous allez voir, bien sûr, et cet écart-là peut vraiment être une différence entre la vie et la mort dans certains cas. Alors, c'est quelque chose qui est extrêmement important. So, the gap that we are seeing increasingly between the recommendations made by the Canadian Task Force on Preventive Health Care and the practices that are taking place now in provinces, international practices, mean that often this gap between what is recommended and what may well be best practice could well be a difference between life and death for so many Canadians. Alors aujourd'hui, on fait ces demandes, bien sûr, à la réforme au groupe d'études. Il faut, bien sûr, mettre en place les meilleures pratiques possibles. So today, these eminent doctors from across Canada are talking about the importance of task force reform and the importance of ensuring that we have the best possible healthcare system.
I'll go ahead and introduce our next speaker. I'm Stephanie Levitz. I'm moderating today's press conference. Our next speaker is Dr. Fred Saad, who is the Director of Prostate Cancer Research at the Montreal Cancer Institute.
Thank you for this opportunity. So, just as an introduction, I'm a urologic oncologist that has dedicated almost all of my 32-year career in treating and doing research in prostate cancer. Unfortunately, I'm faced with treating too many patients dying of prostate cancer on a daily basis due to delayed diagnosis. Yes, we have made great strides with new therapies that give patients hope and are keeping our patients alive longer that are unfortunately diagnosed with incurable disease. But the healthcare costs and enormous side effects for patients and their loved ones are truly disheartening. Most importantly, the pain and suffering due to end-stage bone metastatic prostate cancer is something no one ever wants to face for themselves or their loved ones. Prostate cancer is the most common cancer diagnosed in Canadian men, and unfortunately, the third leading cause of cancer death. Screening has proven to significantly reduce mortality. Yes, as the task force claims, there is a risk of overdiagnosis and treatment if all men are screened, biopsied, and treated. But Canada has led the way in not treating patients diagnosed with low-risk, non-life-threatening prostate cancer, thus reducing the risk of overtreatment. And more recently, with the use of new diagnostic methods such as MRI, we have ways to reduce the need for biopsies in patients without cancer and even reduce the risk of diagnosing cancers that do not require treatment. And that may be a source of unnecessary stress. This is not taken into consideration by the task force recommendation. The task force recommendation against screening is outdated, overly simplistic, and goes against all other guidelines that encourage shared decision-making with patients. This has led to an increase in patients presenting with advanced, incurable stages of the disease. The cost and morbidity, as well as the increased risk of mortality due to delayed diagnosis, is underestimated. I regularly see patients who ask to be screened, only to be denied due to the task force recommendation, and ultimately present with an incurable stage of the disease. These patients feel let down by the system, and their physicians live with enormous regret. As we saw in the recent Lancet Commission, death due to prostate cancer is increasing in men whose life expectancies are increasing in countries which have not had prostate cancer as a priority. Unfortunately, this is what we are beginning to see and hear in Canada due to recommendations such as those made by the task force. Let me conclude by saying that we are way beyond the era of every abnormal screening test leading to a biopsy and every biopsy leading to treatment. Canadian men deserve to have the right to decide what is important to them, and family physicians need to stop being confused by recommendations that go against logic and evidence. Thank you very much.
Thank you, Doctor. Our next speaker is Dr. Paul Wheatley-Price, the University of Ottawa Faculty of Medicine.
Thank you. Thanks for the invitation to be here today. I run our lung cancer oncology group here in Ottawa, and I'm the immediate past president of Lung Cancer Canada, which is our national charity that supports awareness and education and support for lung cancer patients and their families. I'll just tell you a quick story. Last October, I was here in Ottawa doing a clinic. I met a guy for a new consultation with a diagnosis of lung cancer. It's not his name, but for the purposes of today, I'll call him Ray. So I saw Ray on a Thursday. The week before, he'd driven his 9-year-old granddaughter to school and was well enough to do that. But by the time I saw him just 1 week later, his health was very tenuous. He was extremely sick. And in fact, the next day, we arranged for him to be admitted to the hospice. That's the Friday. He died on the Saturday. Ray would have been eligible for lung cancer screening. Lung cancer is the most commonly diagnosed cancer in Canada, around 30,000 cases a year. Unfortunately, it's by far and away the leading cause of cancer death, around 20,000 cases a year. And the reason for that primarily is, like Ray, half of the time when we diagnose people with lung cancer, it's already stage 4, which is incurable. Lung cancer screening with a low-dose CT scan, so safe, low radiation exposure from the scan, has the ability to take people, instead of being diagnosed at stage 3 or stage 4, which is 3/4 of the cases, for people diagnosed with lung cancer through screening, 3/4 of them would be stage 1 or stage 2, which is curable, and the odds are flipped to the patient's favor. The Canadian Task Force issued their recommendations back in 2016. They made just a very weak recommendation for screening, and that, unfortunately, recommendation has been essentially ignored by experts and provinces. British Columbia was the first to initiate a lung cancer screening program. Ontario now has a program. Nova Scotia has just announced. Alberta, Quebec, other provinces are in the process. So they've really seen these guidelines as essentially not fit for purpose. Canada joins many other Western countries with screening programs. So what we would like, what I would ask on behalf of Lung Cancer Canada and the lung cancer community has been our number one advocacy ask for many years, which is to have lung cancer screening available across the country. We would like the task force to update their recommendations so that when programs are available, as they are now in many places, family doctors and those who are making the referral will be able to easily reference and make those recommendations. And further, we'd like to ask, seeing as we're here in a federal meeting, that the federal responsibilities for healthcare for Inuit, First Nations, Métis populations, veterans, these are other populations that are clearly at risk of lung cancer and would benefit from really updated policies. So for Ray and for the thousands and thousands like him, we really have an opportunity here, and I would really seek some support in updating these guidelines. Thank you.
Thank you, Doctor. Our next speaker is Dr. Martin Yaffe, co-director of the Imaging Research Program at the Ontario Institute for Cancer Research.
Thank you. I've been doing research on breast cancer and screening for about 45 years. And I'm here today because of the deplorable situation where hundreds of Canadian women are dying of breast cancer each year, and these deaths are avoidable. The problem is that women and their doctors are receiving dangerous guidance on breast cancer screening from the Canadian Task Force on Preventive Health Care. Besides the unnecessary deaths, many women also undergo harsh therapies for advanced cancer when their diagnosis is delayed. Much of this death and suffering could have been avoided if Canadian screening guidelines had been based on modern scientific evidence. The task force is supposed to provide guidance to our family doctors and health agencies on intervention to save lives and improve health. Ironically, the task force members have little or no expert knowledge about breast cancer. And to make things worse, the task force leadership demonstrates a strong bias against earlier detection of disease. Although it's called the Task Force on Preventive Health Care, perhaps a better name is the Canadian Task Force on Preventing Health Care. A large Canadian study published in 2014 showed that there were 44% fewer breast cancer deaths in women who begin mammography screening in their 40s compared to those who don't get screened. And similar large benefits have been seen in over 20 studies, modern studies done in various countries around the world. But the task force, in its current recommendations, have refused to look at this evidence, preferring instead to focus on studies done 40 to 60 years ago, when methods both for screening and for treating breast cancer were primitive compared to what is currently done. They continue to recommend against screening for women in their 40s and also for those women who are over age 74, making it difficult for these women to take actions to protect their own health. This spring, the task force is supposed to release updated guidelines, but I'm very concerned that once again, as in 2011 and 2018, the process will be biased against early detection, and lives will continue to be lost. Our mothers, our sisters, our friends, our daughters, as many as 700 each year in Canada. The U.S. Task Force is now recommending lowering the age to begin screening from 50 to 40. But just 3 days after that U.S. announcement, the chair of the Canadian Task Force stated publicly that she saw no need to update its guidelines. They had made up their minds even before they began their own Canadian evidence review. This is unbelievable. The task force is supposed to receive its evidence from groups of scientists who independently review and analyze available data on the benefits and harms of breast cancer screening. I was invited to work with one of these groups, and what I witnessed was pressure by the task force on those scientists to include very old data and to analyze new data in a way that makes the benefits artificially look smaller. Also largely ignored are women who are at greater risk of worse breast cancer outcomes: Black women, women with dense breasts, and those from lower socioeconomic groups. The previous health minister promised that modern evidence would be used for this guideline update, and even provided $500,000 to the task force to facilitate its work. But their anti-screening bias is still obvious in the way that they're currently operating. Because the task force guidelines ignore the best modern science, support for them is crumbling. 8 of the provinces are going their own way and have or will reduce the starting age for screening below age 50. The Canadian Cancer Society and the Association of Nurse Practitioners have withdrawn their endorsements of the guidelines. The Canadian Task Force on Preventive Health Care has gone off the rails. And as you've heard from my colleagues, this is not just in the area of breast cancer. We call on the Public Health Agency of Canada and the Minister of Health to urgently reconstruct the task force so that it becomes accountable to Canadians, and to incorporate experts in a meaningful way to formulate helpful and relevant guidelines based on current knowledge. Canadians truly deserve better. Thank you.
Thank you, Doctor. And our final speaker is Dr. Shushiela Appavoo, spokesperson for the Coalition for Responsible Healthcare Guidelines. Over to you, Doctor.
Thank you for this opportunity. I'm a physician deeply disturbed by the guidelines put forth by the Canadian Task Force on Preventive Health Care. I'm representing the Coalition for Responsible Healthcare Guidelines today, Our group advocates for policies rooted in scientific research and practices that prioritize the well-being of Canadians and their equitable access to healthcare services. Many of the major task force guidelines fail to align with recommendations from experienced content experts and specialists, as you've heard today. For example, the existing guideline, this is partly at least because of the makeup of the groups developing the guidelines. For example, the existing guidelines for breast and prostate cancer screening were not led by experts in breast or prostate cancer, but by experts in kidney disease. Unfortunately, the relevant medical experts were not granted significant input into the guideline process. This is deeply concerning as these guidelines impact millions of Canadians. The consequences are grim. Current task force guidelines often limit access to critical life-saving screening and result in later stage disease, and later diagnosis is associated with greater suffering, death, and increased treatment costs. Let's look at colorectal cancer for as an example. It's estimated to have caused 9,300 deaths in Canada in 2023. Despite the significant toll it takes, the current task force guidelines directly contradict the recommendations of specialists like gastroenterologist Dr. Ian Murray, who wrote in response to the 2016 task force guideline, the task force suggests that colonoscopy does harm, and that he then goes on to say, we are concerned that there could be more harm done when cancers are missed. Also alarming, the 2013 Task Force Cervical Cancer Guideline recommends Pap test screening instead of more modern HPV screening. HPV screening is better than Pap tests at decreasing the chance a woman will actually get cervical cancer, invasive cervical cancer. This guidance has put Canada years behind countries like Australia and the UK, which started performing HPV screening as early as 2017. Canadian women are developing avoidable cases of cervical cancer because of this weak national task force leadership. The provinces are finally ignoring the task force, listening to experts, and are initiating HPV screening, and as you've heard, also initiating screening of women below 50 for breast cancer. But this is happening piecemeal across the provinces, and again, the weak task force leadership has led to unequal access for women across Canada. Finally, I want to highlight concerns with the task force's lack of consideration of Canada's diverse population. The task force consistently overlooks diversity, disregarding the unique healthcare needs of specific demographic groups. In my realm of breast cancer screening, for instance, I'm deeply troubled by the task force's reluctance to take into account the heightened risk faced by Black, Asian, and Hispanic women in their 40s. For instance, Black women are 40% more likely to die of breast cancer if they get it, and they're much more likely to get breast cancer in their 40s. So failing to screen in the 40s puts these Canadians at greater peril. By weighting their decisions based on research conducted on nearly exclusively white women, the task force perpetuates racial inequities in healthcare access and outcomes. And I believe you have a handout. You will see further fundamental problems with the task force accountability processes and guidelines in that handout. Because of these grave concerns, again, we call upon the Minister of Health and the Public Health Agency of Canada to take immediate action to restructure the Canadian Task Force on Preventive Health Care. We want to see a robust accountability structure, greater transparency, and the meaningful involvement of experienced experts in the development of responsible healthcare guidelines. Lives are at stake. It's our duty to prioritize the well-being of all Canadians. Thank you.
Thank you very much to our guests. We will now move to the question and answer portion of our event. We do have some colleagues online today. Colleagues online, I ask that you use the raise hand function if you do have a question. We will start with questions in the room before moving online. So again, if you are online, please use the raised hand function and I will call on you after. But for now, we will start in the room. Over to you.
Hi there, Marina von Stackelberg with CBC News. Thanks for taking our questions. My first question is, where do you think the breakdown has happened in this task force? Where is it that you're at this point now?
Do you want to take that?
Maybe I'll start. I think part of the problem is the lack of a governance structure where there's proper accountability of the actions of the task force and even the appointments of members to the task force to the people of Canada. There seems to be a bit of a club where the people who are joining the task force seem to share the same ideology. And, this has led, I think, to an attitude which I think you've heard from all of us tends to be against earlier detection and diagnosis of disease. So I think that's a big part of it. I also think the current leadership in particular has a very strong anti-screening attitude, and this has been reflected in the way they've operated and have cherry-picked data coming from various sources. Finally, there's a kind of a mechanism where the analysis of data is carried out by different disparate groups in the country. There's 3 or 4 different groups, and it's siloed. So there's very little transparency in terms of the ability to see what other data the other groups are bringing to the table and basically have a holistic view of the evidence.
Anyone else want to answer that, or?
I will. I'll just reinforce what he says. I think I think Dr. Yaffe has covered the points very well. I think there's a very fundamental problem with the lack of accountability. There is no way to change any of the guidelines. Once a guideline is set, it's set in stone, and the guidelines are often not changed for a long time. In fact, out of the guidelines that have been developed since the task force, this iteration of the task force started in 2010, only one guideline has been fully updated, and that's the breast guideline. And so there are guidelines, including guidelines that were developed in 2013 and 2014, which are still extant. And if I may, a few people have kindly made themselves available for questioning about the impact of the patient outcomes when patients have late-stage diagnosis, so that you can gain a deeper understanding of the human toll of these inadequate guidelines. I'll introduce, if I may, Ms. Carolyn Holland, who was diagnosed with advanced breast cancer in both breasts with lymph node involvement at age 43 after having never been told about screening mammography in her 40s. Dr. Hassan Shinasa is a gynecologist who deals with cervical cancer. He also chairs the Canadian Network for International Surgery, and he can speak to some of the problems with advanced cases of cervical cancer that he's seen. Doctors Jean Seeley and Anna Wilkinson are a breast radiologist and GP oncologist, respectively, and they are both accomplished researchers into some of the problems that have arisen from the poor task force breast screening guidelines, and also the exponentially higher financial costs of later stage breast cancer.
I have a backgrounder that contains some information from their research about the costs of late diagnosis, so they can speak to that.
If we can continue, just focus on our portion of the conference, which is questions. Marina, follow up.
Thank you. You talked about how this group is very much against over-testing, and that's something we've heard of before, the risk of testing people too much, both a financial risk and also a health risk. So you touched on this a bit, but can you explain why you feel that they are going too far onto the side of not wanting more testing?
Go ahead, please.
There's a couple of issues. I mean, basically, it's a matter of benefit versus harm. Benefit is saving lives, and also adding years of life to people who might die early and be robbed, their family might be robbed of them. Basically, the economic cost of people in the midst of their careers who lose time in their career due to breast cancer, balanced against the harms. And what are the harms? There's 2 that are stated. One is called a false positive. False positive means you get a screening examination, it's not 100% clear that there's nothing there, so they ask you to come back for additional imaging. The task force treats this as an enormous harm, and it's very hard for us and for patients to balance this idea of being called back and being anxious transiently for a few days while things are sorted out, compared to the chance of having a cancer go undetected and you end up either dying from it or being treated for very advanced disease. The other issue is what's called overdiagnosis, and it's suggested by the task force erroneously that many of the cancers that are found are never going to develop into something dangerous. It's true that some cancers just grow for a while and sit there, but it's impossible to know in advance which those cancers are. So the suggestion by the task force is, why not just put your head in the sand and ignore the fact that you may have cancer, rather than manage a cancer in an intelligent way. So I think that's where we're stuck right now. It's a matter of attitude.
Right, if I can just add, because I think we hear a lot about the risk of overdiagnosis and overtreatment of prostate cancer. But we've come a long way to address that. And I think the task force avoids the issue that we can personalize both the diagnosis and screening and personalize the treatment, which is, outdated with 10 years, and the input that came from experts was basically ignored. And data now is very compelling that we can do a much better job of avoiding this overdiagnosis and especially the overtreatment. And I think Canada, we can be proud of having led the way internationally in doing that.
We're going to go ahead online to questions. Nicole Ireland with the Canadian Press, please go ahead.
Hi there, can you hear me?
Yep, we can hear you.
Wonderful, thank you so much for taking my question. I guess I'm wondering, the task force itself is, according to the website anyway, it's made up of voluntary members. Have they been actively blocking subject matter experts, specific subject matter experts like you folks from being part of that decision making? What's stopping, I guess, subject matter experts from participating in making these guidelines?
I think it's a small group of methodologists, largely, that are members of the task force, and involvement in the guideline development process is sort of by invitation only. And content experts are consulted, but have no vote. And there's no way for the content experts or specialists to actually significantly influence the content of the guidelines.
There's another aspect of it, and that is that to some extent, some of the content experts are selected by the task force to work with them because they share the same ideology. That's part of it. The other is that other experts are simply, as Sheila mentioned, they don't have a vote, and their input is minimal, and it has minimal effect on the decisions that are made by the task force.
Go ahead for a follow-up, Nicole.
Yeah, thank you. In terms of the breast cancer screening guidelines, my understanding from looking at some of the documentation at the task force is that that guideline change is supposed to, as you mentioned, is supposed to be happening this spring. So do you know if that guideline is going to, in fact, bring in the screening allowed at 40 years of age? Or are you saying that they may not change the guideline from where it is now?
Well, I'm doubtful that they'll recommend a change. The chair of the task force actually said, as I mentioned, that she felt there was no need to change the recommendations. And that's after the U.S. decided to reduce the age to begin screening. And as you know, 8 provinces have already indicated that they're going to go and reduce, in some cases they've already reduced the ages to begin screening. There's no indication that they're planning to reduce the age. And I mentioned I worked with one of the evidence groups, and all of the input we've received and the pressure that we've felt is to focus on older studies, which tend to show less benefit because simply things were more primitive 30, 40, 50 years ago. We have much better, as Dr. Saad mentioned, we have much better techniques to find cancer and to avoid overdiagnosis and overtreatment.
Does anybody else on the panel want to weigh in on that one? No? We'll come, because we have a few more minutes, we'll come back to the room. And Marina, go ahead.
Thank you. I guess I'm curious too about, we're seeing research that shows that younger people are being diagnosed with cancer. Are you concerned about the ages right now that the task force has put out?
Yes, there is evidence globally that breast cancer in premenopausal women is rising. We see that in our clinics. Sticking to old research biases against that. So if you know that breast cancer incidence in young women has risen steadily over the last 40, 50 years, and they are only, they are heavily weighting studies that are 40 to 50 years old, they are, sort of automatically and systematically excluding some of the benefit to modern day 40-year-olds.
And the same thing in prostate cancer, we're seeing a higher incidence, and we're seeing a spike in aggressive late-stage disease when patients turn 50, where there is at least some attempt to screen, and those patients would have been caught if we were able to start earlier. And there are high-risk groups that we know, and we talked about some racial disparities, and people of the black race, there are other genetic abnormalities, and they're totally ignored, and we have these ways of being able to diagnose these patients earlier. And I think that is something that's very unfortunate when patients come in with metastatic disease that could have been avoidable in patients at higher risk.
Maybe I could just add from a lung cancer perspective, CPAC, that's our CPAC, not your CPAC, Canadian Partnership Against Cancer. They produced our national cancer strategy, and lung cancer screening is highlighted as a key of key importance in the 2019 to 2029 strategy. And I think what I'd like to see, is the task force being far more in line with not just provinces that are going ahead and making their decisions as well, but bodies like CPAC. And then allowing some degree of flexibility. So with respect to your question about age, the Inuit population have probably the highest rates of lung cancer anywhere in the world, and on average are diagnosed 10 years younger than in the Canadian South, if you like. So these guidelines need to allow that flexibility for local context, and particularly for areas of specific need.
You've touched on this, but the average Canadian is going to say, well, if we know this research and there's new research, why is there such a delay in this task force? Why do you think there is this delay in your eyes?
Your guess is as good as ours. I mean, we've really pushed them, and I've been pushing them since 2001, really. This has kind of been a perennial problem, but it's been getting worse, to look at the latest evidence. One of the aspects is they've insisted at looking only at randomized clinical trials, which are a great way of studying disease issues. But we can't do an $80 million trial every time there's a new question associated with a medical issue. We have to use other sources of information. I mentioned the large study. It's called an observational study done across the screening programs in Canada on breast cancer, showing across the board 40% reduction in mortality for women getting screened and 44% for women who started screening in their 40s. The task force has refused to look at that evidence. Perhaps they'll look at it this year, but there's no strong indication that they will.
A few years ago, I met with the Surgeon General to talk about lung cancer screening for the Canadian forces and veterans. And their team came and highlighted that the task force recommendations for lung cancer screening were weak, and therefore they were not going to adopt this. Why we haven't been able to update those is unknown to me, but the lack of update provides a barrier for groups like that. And so at the very least, apart from the procedural, perceived biases, selection of panels, just the delay in doing anything, it seems to me a bit baffling.
I wanted to add a little something. We've talked about some of the provincial clinical practice guidelines moving away from the task force practices, but unfortunately, a lot of family physicians are taught and trained to follow the task force guidelines. So despite the clinical practice guidelines, they may still adhere to the task force practices. And I know from my work in breast cancer, provincial breast cancer screening, that the strongest association with compliance or with a woman actually going for her breast cancer screen is whether or not her doctor recommends it to her. So if her doctor is not recommending it to her, it doesn't matter what the provincial guideline allows, the woman is less likely to go for her screen. So it is really important to give family doctors appropriate and adequate information on who to screen and when to screen.
Maybe I can just add to that. The task force is advocating shared decision-making between the health provider and the patient, but unfortunately the information given by the task force to the doctors is erroneous. So the doctor is not in a good position to have that discussion. Patients, there are benefits and limitations associated with screening, and individuals should make their own decision based on being well informed. But currently, they're really not getting the quality of information that they need to make those decisions.
We'll conclude with just another round of questions online. So, Nicole, you'll have one question and one follow-up, and that will bring us to an end for today. Go ahead, Nicole.
Thank you. Specific question about prostate cancer, because I found it, I did try to look up the task force guidelines and I found it very confusing. So are they in fact not recommending PSA testing sort of at all, or just wondering if you could clarify for me what the existing guidelines are for prostate cancer, PSA for PSA testing in particular?
So I totally share your confusion, and we've been, I mean, those guidelines are about 10 years old, and we've made a huge amount of progress. And actually, the Canadian Urologic Association and many of us have come back and said there's new data to look at, and there are randomized trials in countries where there isn't easy access to PSA. And there was clearly over a 50% reduction in the risk of mortality when you can do a properly done study without contamination of easy access to these tests. And this is basically ignored. And the harm with the Canadian guideline was that it was based on the US task force that actually recommended against screening, as if it was a harm. And since then, the US has come back and said, we made a mistake, and they readjusted, but the Canadian hasn't. So, and to come back, for family physicians, it becomes very confusing. And why would you open a can of worms when it's unclear what to do? Just avoid the whole topic. And that's what we're seeing. When patients ask to be screened, they're being told no, the guidelines recommend against it. Not only to stay neutral and allow the patient to make a decision, but it's actually against. And we're seeing, with the rise in life expectancy, we're seeing an increase in the morbidity and the mortality. And I can't take this 30, 40 metastatic patients a week that I see that probably in large part could have been avoided.
Go ahead with a follow-up, Nicole.
Thank you. I guess just in conclusion, I know you're calling for reform of the task force. Are there a couple of specific asks of what you want to see happen here?
Well, maybe I'll start. I mean, we have been in discussion with the minister's office, and I think reform is difficult because of the essential structure of how this task force was set up. The minister's office has very little flexibility with what they can do. We're moving towards a feeling that there has to be really a rebuilding from the ground up of the task force with a proper governance structure.
Okay, that brings us to the conclusion of today's press conference. Thank you so much to our guests for being here, and have a wonderful day.